Yeah.
So ketones either in the urine or
Blood.
in the serum, blood, excellent. Hyperglycemia and
metabolic acidosis.
mainly metabolic acidosis. Yeah. Is it type 1 or type 2 diabetes?
Type 1.
Type 1.
Type 1. Can happen in type 2 or لا؟
لا.
أبد؟
لا شكل أكيد أتوقع.
Less likely, but it can present in type 2 diabetes. Commonly in type 1 diabetes. Like what about the HHS?
Type 2.
Mainly type 2. It's in elderly patients. Mainly they present with HHS. عادة the first presentation of type 1 diabetes, the patient will present with
diabetic
DKA.
kidney.
هذا غالب. راح تشوفوها يمكن بالتخصص البيضاء. Young adult 15, 14 بالأعمار هذه up to 20 they present with tachypnea, plasmal breathing, acetone prayer, and then they check the blood sugar, they found DKA. Yeah? They found hyperglycemia, metabolic acidosis, and ketones either in the urine or in the serum. But as we discussed, we have three items that should be met to diagnose patients with DKA. The first thing is hyperglycemia, and the cut limit for us is more than 200 milligram per deciliter. Presence of ketones either in the urine or
blood.
in the blood. How we test the urine and how we test the blood. ايش اللي تشوفه في البلد؟ تشوف ايش؟ شو اسمه ketones اللي تشوفه في البلد؟ ايوه بيتا هيدروكسي بكتيريات او اسيتو اسيتيت. شو نشوف في اليورين؟ كنت شفت اليورين ديبستيك؟ It's one of the physical, we call it one of the physical examinations in either internal medicine or legal. You urine dipstick. And once you just stick the dipstick in the urine, you will get the result يعني within seconds. طيب what about the metabolic acidosis? How we follow?
urine diagnostic يكون diagnostic يعني اعتمد على
ايوه طيب طبعا there is a level of the urine dipstick احنا نقول 1 plus 2 plus 3 plus or 4 plus هذه degree of ketones in the urine. عادة to be significant if it's more than 2, 3, 4. طيب how we diagnose, how we get how we identify metabolic acidosis?
pH.
So we should get what?
blood pH.
Blood gas. Right? Either venous blood gas or arterial blood gas. شو نشوف في blood gas? pH تصير فيها. How we define acidosis في pH?
less than 7.
Less than
7.
7. Point
1.
24. 50. 70. Trico. Any pH less than 740, this is acidemia. الأسيديميا ممكن تكون metabolic or respiratory. كيف نعرف إنها respiratory acidosis?
carbon dioxide.
CO2 تكون low or high?
High.
We have a low pH and high CO2, this is respiratory
acidosis.
We have a low pH and low bicarb, this is
metabolic
acidosis. And we'll have, inshallah, data interpretation about how to interpret blood gas. But for DKA, you should have a metabolic acidosis. And we mean it by metabolic acidosis and pH less than 740 and bicarbonate less than 18. Like how we classify severity of DKA based on mainly based on the pH. So if the pH less than 70, this is severe DKA. If it's between 7.24 or 7.0 to 7 less than 7.24, this is moderate. More than 7.25, this is mild DKA. Just to summarize how we classify DKA, it's mainly based on the pH. واضح لكم؟ طيب في البلاد جاز type of metabolic acidosis, how many type of metabolic acidosis تعرف؟ how many types of metabolic acidosis؟ قبل ايوه ايوه anion gap or non anion gap or احنا we call it anion gap metabolic acidosis or normal gain عفوا normal anion gap metabolic acidosis. كيف نحسب الاناين جاب؟ صوديوم كلورايد بوتاسيوم او ولا بيكربونات وعادة صوديوم بلس بوتاسيوم ماينس كلورايد بلس بايكربونات. كذا جنرال رول صوديوم minus chloride minus bicarbonate, you will get the anion gap. Sodium minus chloride minus bicarbonate. واضح لكم؟ يطلع لكم الاناين جاب. كم النورمال اناين جاب؟ الرينج حقنا كم؟ ايوه كم؟ Okay, 8 to 12. Excellent. This is the normal range of anion gap. If you have calculated the anion gap, it's more than 12. This is we call it anion gap metabolic acidosis. في الدي كي اي تعطيكم anion gap ولا non anion gap؟ ايوه تعطيكم anion gap metabolic acidosis. كيف تعطيكم anion gap؟ انكم تفكروا انه البايكارب will be very low، معناها انه الanion gap راح يزيد. واضح لكم؟ طبعا هذه راح تاخذ عليها سيشن كامل ان شاء الله. طيب ايش الكوزز او البريسبتنس للدي كي اي؟ most common is يجيكم مريض type 1 diabetes and he missed his insulin dose. هذا most common. Or he's not compliant to the diabetic diet.
Okay.
Like what other causes غير الانسولين missed dose؟ ممكن ايه؟ infection either UTI pneumonia. طيب it can exacerbate the DKA. What else؟ alcohol intoxication. ممتاز. ايش بعد؟ احنا عندنا insulin missed dose, inflammation or infection. Inflammation مثل ايش؟ ممكن patient he present with pancreatitis, cholecystitis that will lead him to DKA. ايش بعد؟ ممكن he present with MI. Right? So MI that might precipitate DKA. Or he might present with bowel ischemia. Right? So not all DKA because of missed insulin dose. It might be something else. Right? But the most common is missed dose of insulin. طبعا هنا الباب physiology of DKA نعرف ان الكاونتر ريجولاتوري هرمون اللي هم ايه؟
الصوديوم
عندنا الانسولين والكاونتر ريجولاتوري هرمون للانسولين
الجلوكاجون.
طيب وفي اذر هرمونز اللي بنفرن طبعا في الدي كي اي او في hyperglycemic occurs in DKA because of low insulin that will lead to increased glucagon. ايش راح يعمل لكم
hyperglycemia.
hyperglycemia by خذناها في البيسكس glyconeogenesis or glycogenolysis. And the other pathway اللي هو development of ketosis, how the body converts to ketosis by using fatty acid. So we use the fatty acid as substrate for energy. Then it will develop the ketogenic state of the liver, and will decrease the ketones clearance. So mainly hyperglycemia because of low insulin that cause high glucagon compared to the cascade or substrate for energy formation to the fatty acid oxidation. طبعا هذا الجدول or diagram summarizes the pathophysiology of DKA. The end result will be hyperglycemia and ketosis. Hyperglycemia, it will cause polyuria, polydipsia, and dehydration. What we mean by polyuria? Increase urine output. أيوة. طيب والبوليدبسيا؟
عطش ثيرستي عطش
أيوة. Increase
water intake
أو increase the thirst mechanism. طيب polyphagia؟ طبعا based on the symptoms أو based على mechanism, so the patient will have hyperglycemia, increase the water intake, increase the urine output because of the galactosiuria. That will lead to dehydration. What's the signs of dehydration?
increase heart rate
Dry mucous membrane, tachycardia, hypotension. ممكن نشوف other signs or symptoms of the precipitant cause that cause DKA. ممكن إذا كان مثلا pancreatitis, he will present with abdominal pain. Cholecystitis might present with abdominal pain. MI, he might present with chest pain or gastric chest pain, nausea, vomiting, diaphoresis. The classic signs of breathing in DKA will be
Cosmic respiration
سميه ايش؟ classic symptoms or classic signs when you have a patient with DKA. كيف تشوفوا how he present with breathing pattern?
deep
Rapid and
deep
shallow breathing. سميه ايش؟ Calcium breathing. هذا classic يعني تشوفوها. It's a classic for DKA. And why he's doing rapid and shallow?
compensated acidosis
compensate for
acidosis
يسوي
Alkalosis.
compensation. راح يسوي
alkalosis
what type of alkalosis?
respiratory
Excellent. So he's washing out the CO2 to compensate for metabolic acidosis. طبعا it might يعني get more complicated. It might affect the level of consciousness. So يعني DKA mortality around 1%. The overall mortality of the DKA cases. So how we diagnose DKA? احنا قلنا أول شيء check the blood sugar should be more than
250
Then you should check the blood gas and urine or serum for ketones. طيب ايش هذا؟ انا كاتب هنا ال SGLT2 هذا ايش؟ مر عليك مرة؟ ايوه هذا ايش؟
حقت الميديكيشن
صوديوم جلوكوز
الدايبيتس
صوديوم جلوكوز ترانسبورتر 2 هذا ايش نستخدمه في ايش؟ تريتمنت اوف
دايبيتس
diabetes type 2 صح؟ حتى sometimes nowadays we use it for heart failure with diabetes because of decreased risk of
ماي
mortality and cardiovascular diseases or cardiovascular event with the patient who present with diabetes, type 2 diabetes. It can cause decay.
ايه بس
One of the side effects of the SGLT2 inhibitor is to cause glycemic DKA. And they call the patient normal blood sugar, but he has a DKA in terms of he has acidosis and ketones in the urine. Okay? This is commonly we see it nowadays because of the new introduction of these medications. So most of the patients, when you check their blood gas, you found metabolic acidosis. You send for urine analysis, you found ketones. You check the blood sugar, it's normal. And when you take more details about the medication history, you find the patient is on one of these medications. ممكن يكون عنده dehydration. أنت قصدك عشان hyperglycemia؟ صحيح بس ممكن sometimes they present with hypoglycemia بس maybe they would صحيح the severity would be low يعني as compared to the DKA اللي hyperglycemia. احنا we know in hyperglycemia it could cause high output of the urine and he will lose more volume as compared to a glycemic DKA.
علاجهم بيكون نفس علاج الDKA.
أي treatment will be the same.
يعني الجلوكوز عادي عندهم فليش نعطيهم انسولين؟
And why we give احنا will come to it but why we give insulin في DKA عشان نحسن البلد شوجر؟ نحسن البوتاسيوم؟
عشان
What's your goal في الديكاي مانجمنت او الجليسيميك ديكاي؟
نقلل
أسيدوسيس.
الجلوكون.
زود عشان
ايوه صح؟ تسوي؟
نعطي فلويد مع
نعدل الاسيدوزيس. طيب لو your goal في الديكاي is to correct
أسيدوسيس.
الاناين جاب acidosis. طيب no, we don't care about the blood sugar. طيب but by default giving insulin to normalize the blood sugar, but your goal is not blood sugar, your goal is anion gap. You'll stop the insulin infusion once you close the anion gap. طيب حتى sometimes you will see it في الER or في المedicine or whatever subspecialty you have, when a patient with DKA at one point we give them dextrose containing fluid and insulin at the same time because we are targeting normalizing the anion gap. واضحة لكم؟ طبعا one of the presentation or laboratory investigations that you might find في DKA يكون عندهم ايش؟ هايبو او هايبر كاليميا. ايش رايكم هايبو وهايبر كاليميا more common؟ هايبر كاليميا ليش؟ ممتاز excellent. وهو العكس اذا انت اعطيتي انسولين so it will shift the potassium from extracellular to intracellular. عشان كذا احنا it's important to know the potassium level before administering the insulin. Sometimes you'll find leukocytosis that مثلا causes infection like UTI or pneumonia. It has a high amylase lipase that might give you a flu that causes pancreatitis. طبعا الامylase it's not specific, sometimes it increase that not mean in pancreatitis. And how we diagnose pancreatitis? ايوه
فيها انه بان
ايوه
لايف
2 out of 3. So 2 out of 3. ايش ال 2 او ايش ال 3؟ classic abdominal pain. ايش classic abdominal pain of pancreatitis? So epigastric pain radiating to the back. غيره؟ lipase amylase. Any elevation of lipase amylase will consider it pancreatitis or should be double or triple, 3 times the normal upper normal limit. Plus CT finding. So we don't need to have a CT finding. Sometimes we diagnose the pancreatitis based on symptoms and laboratory investigations. And this is how we treat DKA. So the most important in treating DKA is to correct the underlying cause. Then you should replace the volume. So the DKA, the first thing is to correct the cause plus replace the volume. Right? And we don't have numbers of how many liters we give DKA patients. It's depends on patient to patient. For example, if you have a patient who's young and he's very dry, we might give him 2 liters. We might give him 1 liter. As compared to patient who is having heart failure or reduced ejection fraction, so you should be cautious with the fluid administration in such patient. Because if we give him high volume, he might end it by pulmonary edema. Okay? So patient to patient. So depend on your patients, you decide about the fluid administration. But as a general rule, a DKA patient, they require high volume. Okay? Then after aggressive hydration, you should start the insulin. How we start the insulin for DKA? Bolus? Only you will give bolus? بعدين infusion or drip. طيب؟ ممتاز. What's your goal في DKA احنا قلناها normalizing the anion gap. So we'll continue the insulin infusion till you close the anion gap. طبعا if the blood sugar dropped, the DKA dropped below 200, you should start dextrose containing fluid. So switching in fluid from normal saline to D5 half normal saline. Dextrose 5% half normal saline. واضحة لكم؟ طبعا once you close the anion gap, what you will do? If you close the anion gap, you have to تعمله? You will continue insulin infusion? عادة if you close a lane gap, you allow the patient to eat, and you should do overlap between the insulin infusion and subcutaneous insulin. So you will ask the patient to eat and administer the subcutaneous insulin. You will wait for 1 to 2 hours, then you will stop the insulin infusion. واضح لكم؟ This is how we manage DKA. Is it electrolyte, is it important for DKA?
بوتاسيوم.
ايش السيريس electrolyte disturbance في DKA?
بوتاسيوم.
Potassium. Why احنا we are worried about the potassium?
أريزميا. أريزميا.
ايش يصير؟ مثلا عند the patient his potassium is 3 and you administer the insulin. ايش راح يصير عنده؟
بيقل زيادة.
يقل زيادة بعدين he will develop
كوما.
arrhythmias. So he might end it by cardiac arrest and death. لا سمح الله. Okay, so you be careful with the potassium. So don't start the insulin infusion unless the potassium is more than 3.3. So if it's less than 3.3, you should replace the potassium. Then you can start the insulin infusion. If you are on an insulin infusion and the potassium dropped to below 3.3, you should stop and hold the insulin infusion, correct, replace the potassium, then you can resume the insulin infusion. Right? If the potassium level between 3.3 to 5.3, you can't start the insulin infusion, but you should add potassium to the IV fluid. عادة نعطي 20 to 40 milli equivalent per liter. So each liter bag of normal saline will add 20 to 40 milli equivalent of potassium. Right? And we'll continue it as an infusion. Right? And you should check the potassium, electrolytes and blood gas in DK every 2 to 4 hours. عادة احنا في practice every 2 hours we'll do blood gas and every 4 hours we'll do chemistry. So alternating. Yeah. طيب shall we give bicarb for DK?
No need.
bicarb عندهم low.
بيتصحح مع الأنسولين.
Okay, so usually we are not giving. Usually in practice we don't give bicarb infusion or bicarb boluses during DKA because if you treat the underlying cause, you will correct the acidosis. Unless if you have a severe acidosis like pH less than 6.9, you might give a bolus of bicarbonate, like 50 millimole or 100 millimole. Or sometimes if the patient is having like electrolyte disturbance or ECG abnormality with severe metabolic acidosis, we might consider giving bicarbonate bolus. But rarely bicarbonate administration in cases of DKA. So summary, treatment of DKA, treat the underlying cause or the precipitants,
Fluid.
hydration, replace the volume based on the clinical status of the patient, start the insulin infusion, and be careful with electrolytes, mainly the potassium. طبعا the initial infusion rate of potassium will be عادة 0.1 unit per kg per hour. So for example, if his weight is 60, كم نعطيه insulin? So 0.1 multiplied by 60, كم تطلع؟ 6 units per hour. This will be the rate of insulin infusion. So 0.1 unit per kg per hour. إذا بنعطي بولس كم نعطي؟ شو رايكم؟ نفسها؟ عادة 0.14. This is the bolus. نعطي 0.14 bolus بعدين followed by 0.1 unit per kg per hour. هنا طبعا هو كتب لكم هنا 0.1 bolus بعدين 0.1 bolus بس احنا usually in practice we give it as 0.14 bolus followed by 0.1 unit per kg per hour. So هنا another summary or another diagram how to treat DKA. So we divide them على volume, insulin, potassium and bicarbonate. ممكن تشوفون هنا الكولوم اللي على الرايت سايد about the potassium. If less than 3.3, you should not administer
insulin.
insulin. You should correct the potassium, then you can start the insulin infusion. If it's more than 5.3, you should start the insulin, and you don't need to replace the potassium in the fluid. If it's between 3.3 to 5.3, you should add the potassium to the
Fluid.
running IU fluid. Okay, so decay. It's one of the common diseases that you're gonna face for ER. It's decay. So you should know how to treat decay and how to diagnose decay. So رايكم في ال HHS؟ ممتاز.
ما يطلع بسرعة.
ايش how we diagnose HHS؟
blood group
diabetes.
أكثر من 600.
Okay, so the hyperglycemia, but it will be more than 600 as compared to the DKA. DKA usually more than 200. And from its name, hyperosmolar, so you should have
osmolarity أكثر من 350.
high serum osmolarity. Should be more than 300.
50.
20. كم النورمال osmolarity؟ 200. كم؟ ولا 200 بس؟ كم الرينج؟ حد يتذكر؟ 275 to 295. This is a normal serum osmolarity. If it's more than 320, we consider it as hyperosmolarity. This is how to diagnose HHS. So hyperglycemia and high serum osmolarity more than 320. What else? يكون في عندهم ketones?
لا.
Usually absence of ketones. طيب يكون عندهم acidosis?
لا. هذه
Commonly normal, but they might have a mild acidosis. Right? So basically hyperglycemia more than 600 plus high osmolarity. And the most presentation of HHS ايش راح يكون؟ Confusion. هذا أكثر level consciousness. Elderly patient looks dehydrated with altered liver consciousness. Check the sugar is more than 600. Check the renal function. You will have acute kidney injury, meaning by high urea, high creatinine, right? Very dark urine, with low urine output. This is give you a clue. This is
HHS.
طبعا the precipitants is the same as EKA. And presentation mainly because of volume depletion, so the patient will present the same hypotension, tachycardia, dry skin membrane, altered level of consciousness. You check the renal profile, he has high urea, high creatinine. ايش التريتمنت؟ The most important to the HHS is the volume depletion. You have to replace the volume. And the same rules, the DKA, it's patient to patient. So sometimes if you have a heart failure patient or a renal failure patient, you should be cautious with the fluid administration. And usually we give small boluses and we will follow the response clinically. But usually the HHS patient, as compared to DKA, they require more volume. And sometimes we give up to 8 liters of fluid to replace their volume depletion. Don't forget to treat the underlying cause as well. And you should administer insulin. And your goal here is to normalize the running gap?
لا.
What's your goal? Normalize the blood sugar?
osmolarity.
أيوة. Decrease the what? And? ممتاز. By default, if you decrease the blood sugar, it will decrease the osmolarity. طبعا the same. The insulin rate of infusion will be the same, 0.1 per kg per hour. Okay? So the main treatment is fluid, insulin, and don't forget about the electrolytes. So we are giving insulin, so be careful with the potassium. And when we'll stop the insulin infusion في HHS? متى نوقف الانسولين infusion؟ احنا قلنا في DKA if we close the ion gap and be able to eat. هنا متى؟ If we normalize the blood sugar around 200 to 300 plus normalizing the osmolality plus he is able to eat and he regain his level of consciousness. طيب؟ واضحة لكم؟ So it's easy for you now how to treat both DKA and HHS and how to diagnose and how to differentiate between them. واضحة لكم؟
واضح.
طيب DKA عندنا تراياد، ايش التراياد حق DKA؟
هايبرغلايسيميا.
mainly hyperglycemia,
Metabolic
acidosis
acidosis.
and ketones, either in the serum or in the blood, from serum or in the urine. طيب what about the HHS? Hyperglycemia, high osmolality and
No acidosis.
no acidosis and no ketones. And again, the difference between DKA and HHS is usually it happens HHS commonly to type 2 diabetes as compared to type 1 and DKA. Hyperglycemia, degree of hyperglycemia and HHS will be more than 600 usually as compared to
DKA.
DKA. And again, how we treat both DKA and HHS. So there's many diagram algorithm just to make it easier for you how to treat DKA and HHS. The treatment will be the same, fluid, insulin and potassium as needed. احنا قلنا الفوليوم depend على clinical picture of the patient and comorbidities. How we stop insulin infusion في DKA and HHS. احنا قلنا HHS في maintain level of consciousness and normalizing the osmolality with the blood sugar around 200 to 300. This is when to stop the insulin infusion في HHS. The DKA closing an ion gap, the patient able to eat. Then this is the point how to stop the insulin. طبعا هنا حاط لكم criteria for resolution of DKA. The blood sugar should be less than 200 and 2 of the 3, and then pH more than 7.3 and bicarbonate more than 15 and an ion gap less than 12. The HHS and the osmolality should be normalizing less than 320 or regaining of level of consciousness or normal mental status with glucose around 200 to 300. Clear؟
Yes.
ده هذا السؤال واضحة لكم إن شاء الله؟ Hypoglycemia, is it common?
Yes.
طبعا the hypoglycemia it can mimic many diseases. Yeah? How the patient present with hypoglycemia?
Lethargy.
Coma,
Lethargy.
confusion, tremor, dizziness, seizure, that. What else?
Sweating.
Hmm?
Sweating.
ما سمعت.
Sweating.
Sweating. Sweating. Sweating. إيش بعد؟ ها؟ Tachycardia. إيش بعد؟ Hypotension. إيش بعد؟ أبناء أمس stroke. ممكن يجيكم بإيش؟ weakness. ممكن يجي vocality في الإجزاء. ممكن يكون عنده right side pain. Check the blood sugar was very low. You administer dextrose and he regained his power to the right side. So this is how it's important to treat and to diagnose hypoglycemia. احنا قلنا من البداية ABC plus
Glucose
check.
test.
هذا should be في ER. طبعا usually the level should be below 60 milligram per deciliter or sometimes up to 55. طبعا you mentioned most of the presentations or manifestations of DKA. تعرف الوبل triad اللي هو ايش؟
Hypoglycemia.
hypoglycemia, hypoglycemic symptoms and resolution of symptoms after
Glucose.
administering the dextrose. This is we call it water trial, and this is how we diagnose hypoglycemia. طبعا ايش الكوز حقت الهايبوغليسيميا؟
High dose of insulin.
It's depend هل هو non diabetes ولا patient without diabetes. For easier for يعني for us إنه patient who is non diabetes the most common is
insulin. High dose insulin.
high dose insulin مثلا missing meal when he's getting his insulin it will cause hypoglycemia. إيش بعد؟ or يكون على oral hypoglycemic agent. أيه؟ طيب non diabetic وين؟
Fasting.
وين؟ tumor صح؟ fasting صح؟ بس tumor where is the tumor location؟
بالأدرينال. أدرينال الظاهر.
الكدني؟ الليفر؟
Pancreas.
بنكرياس؟
أي
بنكرياس. ايش الكومنز كوز الانسولينوما؟
صح.
طيب ايش الاندوكراين diseases that cause hypoglycemia؟
كرش. لا. لا.
ايوه اديسون
مم.
او adrenal insufficiency either primary or secondary adrenal insufficiency غير الاديسون adrenal insufficiency. up to liver failure liver failure medicine can cause hypoglycemia. ايش وظيفة الليفر؟
تخزين.
ها؟
صح.
ايوه. So if we have a liver failure
ما راح
we'll
يصير
end
فيه
by having
hypoglycemia.
low blood sugar. But it's the liver is the most important part of the body that generates glucose. Okay? So one of the poor sign of liver failure is
Hypoglycemia.
poor prognosis is
Hypoglycemia.
hypoglycemia. So I mean a list of causes of hypoglycemia. So here how to diagnose hypoglycemia. So mainly you check the serum or glucocheck level of glucose, and you have to send for labs to identify the underlying cause based on suspicious or underlying diseases that you have in your mind. طبعا ايش رايكم في اخر شيء هذه this is to treat to
Medication.
diagnose what?
Medication overdose.
Either medications or insulinoma or هذه المفروض انكم اخذتوها في الميديسن اللي هي how to differentiate between different diseases that cause hypoglycemia. How to differentiate between insulinoma from someone who's taking sulfonylurea or someone who's taking exogenous insulin. Sometimes people they inject themselves with insulin or they take extra pills of sulfonylurea and they present it they are with hypoglycemia. So how we differentiate them between insulinoma? By doing pro-insulin, C-peptide. طبعا هذه ما هي مطلوبة عليكم بس this is for your knowledge انكم تعرفوها how to differentiate between the causes of hypoglycemia. How we treat hypoglycemia?
إذا درياكي.
Dextrose ممكن.
أيوة. Is he conscious or unconscious? If he is conscious, so you will give him
عصير.
fluid containing dextrose ولا you will ask him to
يشرب عصير.
يشرب عصير.
ممتاز تقول له اشرب عصير أو ممتاز. طيب إذا كان كذا semi conscious
فلويد.
أو unconscious
IV.
ممكن نعطيه إيش؟
IV.
ممكن أيوة إيش؟ أو عسل.
أي عصير.
طيب طيب not accessible نعطيه دكستروز. طيب إذا أنتم في البيت ما عندكم دكستروز ما عندك ماي بي اكسس عادة أيوة ممتاز جلوكوجون بن عادة any patient with diabetes and he's on insulin عادة يعطوهم اسمه الجلوكوجون بن contain 1 ملغ once they feel the hypoglycemia symptoms, they inject themselves with the pen هذا. But this is how to summarize the management and diagnosing the patient with hypoglycemia. في أي سؤال على الهايبوغليسيميا؟ أو حلقة؟